Department of Medicine Grand Rounds. We have a special guest today, but before that, a few comments. As we do every Thursday, we try to remember for a few minutes people or events that have changed the way we think about medicine, biology, human nature in general. And so we remember a few of those people and events today. So I want to remind you about Max Ferdinand Perutz, P-E-R-U-T-Z. I think I've pronounced it appropriately. He was born this week in 1914. And he was an Austrian-British biochemist who actually shared the Nobel Prize for Medicine or Physiology in 1962 for having done an analysis using X-ray diffraction for hemoglobin. So he was the one who said hemoglobin requires actually 4 proteins that assemble in such a way that allows for the capture of oxygen. And when that oxygen comes in, then the shape of the molecule actually changes. And for that, he won the Nobel Prize. Robert Furchtgott died on this week in 2009 at age 92. But he was an American pharmacologist who shared a Nobel Prize with Ignarro and Murat. And you should remember this because in 1998, they won the Nobel Prize for discovering nitric oxide. So important signaling system for the cardiovascular system, but for many other systems as well. Edward Jenner, everybody knows him as the discoverer of vaccination for smallpox, was born this week in 1749. But for those who are pulmonologists and who use percussion all the time, and even those who are not, and I hope all internists do, you should remember Joseph Leopold Aubrünger. Joseph Leopold Aubrünger was an Austrian physician who devised this technique. And in 1761, he published how to engage in this technique in a journal called Inventum Novum. Inventum Novum. And his father actually had a winery. So he basically would tap on the side of the barrels to know where the wine was. So he transferred that to his patients and described this, but nobody cared. And it wasn't until a Frenchman actually translated this into French in 1808 that everybody sort of paid attention to it. This day in 1988, nicotine was declared addictive, as bad or similar to heroin or cocaine by General Everett Koop. But today is about aging, it's about transplantation, it's about immunity, it's about all these things. So we remember Ilya Mechnikov, who was a Russian-French biologist and immunologist who won the Nobel Prize in 1908. And he did it because of his work with phagocytosis. And as we've described here many times, some of these people finished their careers in university, and their big discoveries actually came afterwards. And many of them actually developed laboratories at the back of the house. So he actually had his own private laboratory after retiring from many years of teaching at a university. And he began to look at how white blood cells phagocytose or engulf microbes. And so for that, he won the Nobel Prize. And so with that, I'll leave you with Dr. Eleanor Lederer, who's going to introduce our guest speaker of the day.
Well, I'm absolutely delighted to introduce our speaker, Dr. David Cohen. Dr. Cohen is a real New Yorker. He was born in New York. I think he attended at some stage of his career every single institution in New York City and remained in New York except for 2 times. He did his undergraduate work at the University of Michigan. He spent some time in Paris and got his master's in Paris, but he came back to New York to go to medical school at the Einstein, internship and residency and at Mount Sinai, and then did his fellowship first at Columbia Presbyterian for his clinical year, and then moved to Boston to Brigham and Women's, where he did his research fellowship, discovered and developed his real interest in transplantation medicine. Since that time, he has had an incredible 3-decade career in studying clinical transplant medicine and is currently professor of clinical medicine at Columbia Pres. His work in transplantation has spanned many different areas, including issues of donation, BK virus. BK virus, for those of you who are not familiar with it, is a relatively recently discovered virus that now poses a huge threat to the long life of transplants, and he is the site investigator for an NIH-sponsored trial in this. Today's topic, I think, is very timely. It's also, I think, very important for internists to recognize that we now do offer transplantation to an older population, and this, I think, 20 years ago, we never would have imagined. So with that, I'd like everybody to join me in welcoming Dr. David Cohen to give today's grand rounds.
Well, thank you, and good morning, everyone. It's a pleasure to come to Louisville. Never been here before. I guess I missed the Derby by a couple of weeks, but maybe the next time I'll get here in time to catch it. In terms of my career in New York, people have two interpretations. I've been to multiple centers. One is no place could stand me, and the other is I was highly desirable, and every place wanted me. So you can make up your mind at the end of the lecture, I guess, which is more likely. But this morning we're going to talk about kidney transplant in the elderly, and I've chosen a title which has been used like multiple times in multiple variations, so I'm giving credit to no one in particular, but it's not original. It's 80 to the new 60, or it's 80 to the new 40, or 30, or whatever you'd like it to be. In terms of disclosures, at the moment, I'm actually relatively free. I only have one through Alexion. I'm on the scientific advisory board for a registry of international registry of atypical HUS patients, and unfortunately, the honorarium is paid to my division, not to me. So actually, I have really no disclosure whatsoever. So by way of a little bit of introduction, the demographics, we all know the country's getting older, people are living longer, and currently about 15% of the population is over 65, as projected to double by 2060, where 1 out of 4 people will be over 65. So this poses challenges in so many different areas. Of course, delivery of medical care is clearly one of them. And one subset of that, one sub-area, of course, is the area of end-stage renal disease, kidney disease in general, and kidney transplantation. So maybe 80 is the new 30. Here's a photo from an 85-year-old man, Mr. Whitlock, who ran the marathon in Toronto in under 4 hours, something I certainly couldn't do. So older people are certainly doing a lot, and this gentleman who's clearly quite a bit younger looks like he's about had it, and Mr. Whitlock is going strong. So that'll be a little bit of the theme today. The population is getting older. The end-stage renal disease population is getting older. For those of you who are not involved at all in nephrology, we have tons of data. As you may hear, maybe it's touchy to bring this up, but there was a bit of a rant on John Oliver's show the other day about dialysis, and one of the things he pointed out was how much Medicare spends on end-stage renal disease. It's a little bit of oversimplification to say, but it is the only single disease entity, essentially, that Medicare pays for. So if you have end-stage renal disease and you've worked, you get Medicare. And it's cost, it's like 1% of something of the Medicare budget, over a total federal budget. It's a huge expenditure. One of the good things about that, of course, people get care. The other thing is that, in a broad sense, the government wants to know what it's getting for its money. And so we have mandated reporting of all kinds of outcomes, demographics, everything you can imagine for all patients with end-stage renal disease. That includes transplantation. And so there are enormous databases which are available to the public, and we get periodic reports that tell us all about end-stage renal disease, and several of the slides will come from that. And several of the papers I'll refer to have used these publicly accessible databases for analysis of what's going on in various populations. So the country's getting older, and end-stage renal disease is getting older. If you look at the prevalence per million, those over 65 have the highest prevalence per million of end-stage renal disease in the country, and it's steadily increasing. And if you look at the number of cases, it's not by far the largest number of cases, but it's one of the most rapidly increasing number of cases, and again, in the over 65 population. So lots of people, unfortunately, at older ages are developing end-stage renal disease. Lots of theories as to why that is. Perhaps we're taking better care of other diseases that lead to end-stage renal disease, and people are living long enough where the kidneys eventually fail and the patients are still alive. So one question is, what do we mean by elderly? And of course, how old is old depends upon who you are. So if you ask people who are between the ages of 18 and 29, they think 60 is really old. If you ask people who are between 30 and 50, they think 69 is old. If you ask people between 50 and 64, they think 72 is old. And if you ask 65-year-olds, like me, we think that 74 is old. So it really depends on your perspective. And I would have to say that many of the articles that I'm going to cite, and I'm not going to repeat this every single time, the populations could be either over 65 or over 60. So it's not the uniform population in all the different things I'm going to cite. The articles go back and forth, and sometimes it's even over 70. Just kind of accept that as it is. So a little bit of a case presentation, something that happens at our center. A 79-year-old man who's been waiting for a kidney transplant came back to see if he's still a candidate. His end-stage renal disease, unknown etiology. He's been on dialysis for not quite 2 years. A history of high blood pressure, psoriatic arthritis, so he takes serious pain medicine for many years. He's had some heart disease, which was fixed up and seems to be stable. He's a retired physician. Never smoked. He's still quite active. He goes to classes at the local university, but he has trouble getting around. He has to use a walker, and he can maybe get 3 or 4 blocks before his arthritis sets in. So really, is this man appropriate for a kidney transplant? He's almost 80 and poses, of course, all the questions which I'll address. What are the success rates? Should he stay on dialysis? Is that a better deal for him? How do we know if he's a candidate? What kind of risks is he at for various complications? Put this in parentheses. I'm not going to really say much about immunosuppression. I don't think there's really time to go into the details. I will say a word or two about that. So our societies have decided that age is not, in and of itself, is not a contradiction. The Canadian Society of Transplantation and the American Society of Transplantation both say there's no absolute upper age limit. When I'm asked, particularly, I say 100. No one over 100 is going to get transplanted at Columbia while I'm there. That kind of usually stops people in their tracks. But, there's no absolute age limit. We want to make sure people have a reasonable chance of survival. We need to periodically reevaluate patients. We need to screen for certain diseases. But age in and of itself should not be a factor in deciding on kidney transplantation. And a nicely worded statement says we should look at biological age rather than chronological age. Sounds very wonderful. How we do that's not so simple. Nobody has a real formula for this. Certainly, if we had, we could just test one thing and know how people would do. That would be wonderful. But that is really, in a sense, the challenge in a simple statement. So if we have more people getting older, more people reaching end-stage renal disease, that does, of course, push the fact that we'll probably have more people getting on the wait list for transplants, and indeed we do. So in the teal color here, you can see that over 65 making up a higher and higher percentage of the wait list. Up to 20% of the people on the wait list are now over 65, and a couple of percent are actually over 75. It's obviously not the biggest group, but there are more people, the higher percentage of the wait list is over 65 than the younger people, which I guess is a good thing in certain ways. So we have more people getting on the wait list, and we have more people getting transplanted, in fact. So this is all data from the United States Renal Data Survey, which, again, has an annual data report, which is accessible to everyone online and has tons of information about kidney disease in the U.S. So this looks at the number of deceased donor transplants over the past 15 or so years, breaking down by age group, age 65 to 74 in the gray line. And you can see that some 20 years ago, there weren't very many, and that has risen more rapidly than any other age group in terms of the number of older people getting deceased donor transplants, patients over 65. If you look at live donor transplants, again, there are almost none back in 20 years ago, and now somewhere between 500 and 1,000 patients are getting live donor transplants, patients who are over 65 years old. So this is a fact of life in the transplant area. These patients are getting access. And if you look at as the percentage over time, it's from a review article from a few years ago from the Johns Hopkins group, the number of recipients age 65 has gone up and is now almost 20% of kidney transplant patients, and several thousand every year age 65 are getting transplanted. So this is an important issue. And in fact, even in the donor population, so this is deceased donor kidneys, nearly 20% of deceased donor kidneys are also in that age group. So the donor population is also getting older. Which poses other kinds of challenges. for kidney transplant. As many of you may know, kidney transplant or oral organ transplant is a unique area in medicine. It's the one single area where we don't have enough resources. There just aren't enough organs for those people who need them. Everyone can have a hip replacement, everyone can get bypassed or stented or any other such thing, but not everyone can get an organ transplant. And so we depend on the trust of the public that we do a good job with these organs to when a loved one, the family member dies, to donate the organs. And this is happening more and more in the older age group, and these kidneys are being accepted and often used for transplant, and that, again, poses a whole number of challenges to the field. Who should get them? How do we use them? How do we know which kidneys are really acceptable for transplant in this population? So what happens when we do this? Is this a good idea or a bad idea? Just because things happen in medicine doesn't, and demographics have pushed things, doesn't mean that it's the right thing to be doing. And how can we learn to do it better? So the first thing is, when we look at outcomes, we have to consider two things. So what's the relative benefit? And this is true in so many areas when you look at statistical analyses of outcomes. There's a relative benefit, and then there's an absolute outcome. And I always give the example, if someone says you have a 1 in a million chance of something happening, and if you do X, it's going to go to 2 in a million, well, you're not going to be that excited. But if someone tells you you've got twice the chance of dying with a given intervention, you might step back and not want to do it. So you have to look at both the absolute risk and the relative risk of transplant compared to the alternative, which for these patients is a lifetime of dialysis. So the first thing I'm going to talk about is the relative risk. And so these are the kind of curves that we have in the transplant area, which looks at the reference line here being staying on the waiting list. And it's normalized to a risk of 1. So if you stay on the waiting list, this is your risk of dying over a 2-year period. If you have a kidney transplant, and these are patients over 70, well, the relative risk in the first couple of months is, of course, higher because sitting on the waiting list, most people aren't going to die in a few months. But when you operate on several hundred or several thousand people, obviously there will be some unfortunate early mortality, so the risk immediately afterwards is higher. But once you reach about 4 months, the relative risk of death on the waiting list exceeds that of having a kidney transplant. And in the long term, and this is a log scale, in the long term, your survival rate is about half if you stay on the waiting list compared to getting a transplant. So the relative benefit of a transplant in those patients over 70 compared to sitting on the waiting list is substantial. And this just shows that same data really in another curve, essentially, where your wait list time to equal survival is about 1.5 years, which is slightly different than your relative risk of mortality. If we look at this in another way, and the expected remaining life years divided by age and sex and the treatment modality of the prevalent population. Again, we get all these statistics from USRDS, and it's available to everyone. So if you're in the older age group and you're on dialysis and you're a man, you're expected between 65 and 69, and the male and female differences are small. Your expected survival is 4.5 years or so. If you have a transplant, your expected survival is 11 years. That's a rather substantial benefit. Obviously, if you don't have end-stage renal disease, your expected survival is 16 years. If you go to the older age group at 75, I think that includes, that combines all the older age groups. Your expected survival on dialysis is about 3 years. With a kidney transplant, it's between 7.5 and 8.5 years, which is actually approaching that for a man of the survival in the general population. So clearly, transplant is a benefit compared to sitting on dialysis. Now we have to be careful that, and this does not really take into account the selection process that goes into being on the waiting list. So this data is just everyone on dialysis, but it's entirely consistent with the previous slide that was patients on the waiting list. If we compare that to other causes of death in the older population, so dialysis is the adjusted mortality deaths per 1,000 patient years. So dialysis is around 200 in the age 65 to 74, and over 300 per 1,000 patient years on dialysis in the older age group. transplant is a third. Whoops. Transplant is a third of that. If you look at all patients on Medicare, obviously you're better off not having end-stage renal disease. But if you look at having cancer, what's your death rate from all cancers in that age group? Actually, having a kidney transplant is similar or even slightly better than having had cancer. It's better than if you have heart failure. Your survival is better with a kidney transplant than patients who have heart failure at that age group. It's not quite as good as just having diabetes, but not having kidney failure, and it's comparable to having had a stroke. And it's better actually than having had an MI. So transplant, when you start to look at it, compared to other things that could happen to you at that age group, is actually not so bad. Obviously, of course, better not to have kidney failure at all. Now, if we look at the sort of absolute outcomes, what are the numbers? And the transplant data is often expressed in three different areas. So what's the actual patient death? What's the cause of how many patients lose their kidneys, which includes dying with a functioning kidney? So most of our data says that if you have a kidney transplant and you're 9 years and 364 days after transplant and you walk out of the medical center and get hit by a bus and you're dead, then you have not survived the 10 years with a kidney transplant. Your transplant is considered to have failed when you died. So that kind of keeps us all honest. But it's, of course, also important to know what's the death-censored graft loss. Those patients who don't die, how many reject their kidneys? So we have three different areas here. So one is the overall patient death. And this is looking at broken down by decades, 60 to 70, 70 to 80, and then over 80. And clearly, this is the 2-year death rate after transplant. There's about 10% in the 60 to 70 group, 15% in the 70 to 80 group, and about 75% of the patients are still alive 2 years later, over 80 having a transplant. But clearly, the older group, not surprisingly, people are going to start dying when they're in their 80s and regardless of whether they have a transplant or not. If we look at all graft losses, you can see it basically parallels death. A huge percentage of the graft loss is actually dying with a functioning kidney, which in many ways is the goal of transplantation. You put a kidney in, you want it to last the patient's entire life, and of course you hope they'll live late until their 80s or 90s or who knows what with a functioning kidney. If you look at the death-censored graft loss, those who reject their kidney, between 90 and 95%, regardless of the age group, still have a functioning kidney 2 years later. So from the transplant point of view, in the older population, transplant is actually amazingly successful. And getting better and better. So this is data from the Johns Hopkins group that looks at the patients over 65, all-cause graft loss by year of transplant. So this includes death. This is in the 90s, late 90s, 2000s, going up to 2009 and 2011. And you can see that it's gotten steadily better and better and better. The percent of people who died or rejected their kidneys has gone way down, and this is the latest curve. It's only had a couple of years of follow-up. So the patients are doing well, and they're doing a lot better than we used to be able to do in the past in the older age group. All is not roses, however. This is data from the UNOS, which is the United Network for Organ Sharing, which specifically collects data on kidney transplant outcomes, as well, in fact, all solid organ transplants, demographics, medications, complications, hospitalizations, et cetera. We have mandated reporting. If you want your program to stay alive, you've got to report all your outcomes to UNOS. So this data looks at the incidence of rejection by age and the death from infection by age. And interestingly, as the patients get older and older, the rejection rate goes lower and lower and lower. So the older people are substantially less likely to have any rejection episodes of their transplant. On the other hand, they're much more likely to die an infectious death. And this is one of the dilemmas that we face in transplanting these patients. When we looked at our own data, we really didn't see much difference in the rejection rate between the over 60 and under 60. It was pretty comparable, actually, slightly higher in the older age group. But the national data shows that it's, and this has been shown many, many times, that older people are less likely to reject their kidneys and more likely to have complications of immunosuppression. Again, this is the death rate from infection after transplant in the first 2 years. You can see that the older you get, the more likely you are to die from an infectious complication after a kidney transplant. So how do we actually balance these risks in patients? So, of course, one aspect of that is choosing the right kidney, choosing the right patient, and putting the two together in the right manner to get good outcomes in this population. So patient selection, who's the appropriate candidate, what tests should we do? While they're waiting, how do we keep track of them and make sure they're still healthy? This is, of course, true for any patient, but particularly in the older age group. What kind of kidney can we get for them? And how do we manage them after transplant? What should we do to make sure they stay healthy? So the first thing that should be obvious, as implied by what I said, is that not all older patients are getting transplanted. So this looks at the prevalent patients with end-stage renal disease per age group and the percent that are waitlisted in the blue. So a few things are obvious. One is that at any age group, an incredibly small number of patients, a small percentage of patients are actually waitlisted for transplant. It's kind of shocking that in patients between the ages of 18 and 39, what percentage are actually listed for transplant of patients on dialysis. And one thing I always say about this data is that we lament that in rough numbers, there's 100,000 people on the wait list for a kidney. Last year was the record year. We did 19,000 kidney transplants, and every year 35,000 patients go on the list. So simple math is that the numbers just get worse and worse. The waiting list gets longer, the waiting times get longer, and it poses a huge number of dilemmas and problems about how do we organize the whole system. But I think that what this shows is that actually that problem is understated. That we say there's 100,000 people on the wait list, but there's probably estimates have shown there's at least another 100,000 people on dialysis who would be excellent candidates for transplant who just aren't listed, and we don't know why they're not listed. Conceivably, they just haven't been properly informed, or they knew someone who had a bad outcome and they just said, I don't want to go there. Or in fact, they have a lot of medical problems and they're not appropriate candidates. But when you look at this, it's pretty obvious that if you get up to the over 80 group, a very small percentage are actually on the wait list. And of course, as the patients get older, a smaller and smaller percentage are deemed appropriate for waitlisting. And so we are very stringent in the selection of who we put on the wait list, not surprisingly. So how do we pick the right patient? Here's Mr. Whitlock again. He would seem like a pretty good patient. If he can do a marathon, this guy who's a lot younger, he doesn't look so good at this point. Maybe it wouldn't be a good candidate. And this is not a HIPAA violation. This is taken from Google Images, so I don't know who it is. There's no name, but this gentleman might not look like a great candidate for a kidney transplant. So obviously, we need to kind of look at what characteristics of patients make them reasonable candidates to move ahead at this age group. Again, assessing chronological age rather than biological age. So what are some of the features we might look at? Well, we know older patients have more comorbidities. And this is from the University of Minnesota, looking at different age groups and what kind of problems the patients with end-stage renal disease have. And so you get over 65, you get not much more diabetes, really. That's pretty common all across the board. You get a lot more heart failure, you get more peripheral vascular disease, you get more coronary disease, and you get more cancer up and down the line. People have had a history of cancer, skin cancer or non-skin cancer. So facing a population with quite a large amount of comorbidity in addition to their kidney failure. There's been some work on which factors predict worse outcomes. Not surprisingly, coronary artery disease, heart failure, peripheral vascular disease are associated with worse outcomes. Those patients who are more sensitized, this PRA indicates what level of anti-HLA antibodies is present in the recipient, which indicates how difficult it will be to find a compatible kidney, and which may place them at risk for rejection following transplant. So these are identified as risk factors for poor outcomes. Another group in Canada looked at higher BMI, patients who smoke, and interestingly, the longer time on dialysis led to worse outcomes. And this is I'm going to come back to that a little bit later. So we have various tools that are used to kind of look at comorbidities and frailty and fitness. And one of the comorbidity index that was used to assess that patients over 70 at the time of transplant actually was the tools didn't work. Most of these tools are actually, many of them are not that well validated in this population. They're not specifically designed for end-stage renal disease, and these are the tools that we have. So this is a major problem in the field, that we are limited in our ability to assess the patients other than some broad categories. Now, in transplant, since 2014, the allocation system has changed quite a bit, and now everyone gets an estimated post-transplant survival time. So when you come for transplant, we plug in a few variables: your age, are you diabetic, how long have you been on dialysis, and have you had a previous transplant? So only a couple of variables, and it spits out your estimated post-transplant survival time. Generally, as a percentage, it doesn't give you absolute years, but it says you're in the top 20%, or you're in the worst 20%, or some number of that sort. And so your EPTS score, the lower number is a better score. So if your EPTS score is 0 to 20, your estimated post-transplant survival in 8 years is very high. And if you're between 80 and 100, it means you, by this scale, your post-transplant survival is actually predicted to be not that good in the long term, or certainly worse than the other groups. And this is used in the allocation of organs, so that patients with the better estimated post-transplant survival are prioritized for what are perceived to be better quality kidneys, so-called longevity matching. This is since the end of 2014. The idea being that we'll get more use out of the kidneys that have more potential to last longer, and they should go into patients who have the potential for living longer. One of the issues is that when you look at how accurate is this in the patients over 65, this is just from an abstract that was just recently presented at the transplant meetings. So this is if your estimate is equal to chance, like flipping a coin. And a perfect scale would go like this, kind of receiver operating curve. And for the younger patients, it's not too bad. The so-called area under the curve is 0.68, which is kind of often what you get in these areas. But for the age over 65, it's actually not a very good predictor of mortality. So even the tools that we use don't really guide us all that well, and haven't really been well validated in this particular population. These tools are made to assess the entire ESRD population. And so we might be using the wrong measure in looking at the older patients. So one of the things that's somewhat intuitive is functional status. The worst functional status patients you would think would have the hardest time after transplant, and this is clearly true. This group looked at 3-year mortality with the highest and lowest performance status in different age groups. And at every age group, those with the lowest function had a much higher mortality at 3 years. And when you get to the patients over 65, it's a huge difference. It's virtually double the mortality for patients with low functional status after transplant, as measured by their scale. So that's clearly an important factor in selecting patients. Another one is dementia. So assessing, many patients come with the family members, spouse who's there, and we've all had the experience when you're asking the patient question, is the spouse answers. And so you get a pretty good history, but the patient, him or herself, hasn't actually said very much. And so it turns out that the risk of mortality and or death-censored graft loss for patients with dementia or any kind of Alzheimer's type dementia is substantially higher at any time after transplant in patients who have dementia. It's almost, of course, by 10 years out, you're taking older patients. 10 years out, you're going to have a lot of problems, regardless, just because inherently in their age. But the 5-year mortality is between 2 and 3 times as much for those patients who have dementia or any form of Alzheimer's disease. So that's another factor that we can look at and use to screen our patients. Another thing that's been shown is actually educating the patient. Many patients come in and think they'll get their kidney, and a couple of days later they'll bounce out of bed, they'll walk down the street, and their life will be completely new again. And it is true for a substantial percentage of patients. But for the older patient, that's less true. And if people are not educated into the idea that this might be a bumpy road, and you might not get back to where you think you're going to get back to entirely. You'll do better than dialysis, but this may not be quite as simple, and you're going to have to hang in there. If the patients don't know that, patients easily get depressed. And so education of the patients has been shown to be quite important. They need to get some idea what the recovery time is, what the possible complications. They may suffer side effects of the medications, and they need to know this in advance. We need to have some idea that they are able to overcome certain obstacles, that in the immediate postoperative period, they may be worse off. They might have been walking when they went to dialysis, and now they've been in bed for a week. They've had surgery. They're on drugs, a lot of immunosuppressive drugs, and they might not be walking right away. And they have to understand that you got to hang in there. They're going to have to take a lot of medications. There are a lot of visits. Follow-up is essential. And patients who don't understand this or are unable to do this are generally not going to do well. So certainly patient education and the ability of the patient, in our estimation, to meet these standards is crucial in success rates. In terms of cardiovascular disease, there's really not a lot of data. This is all kind of common sense. We want to see if they have any degree of heart failure, how bad it is, what kind of coronary disease. We don't really have great data as to what to do with coronary disease. We follow the general guidelines. There's not a lot of specific data. There's lots of papers, but they're mostly just observational in terms of end-stage renal disease and cardiac interventions. We definitely test everyone from a cardiac point of view. Anyone over 70 on our waiting list gets cardiac testing every single year. And one of the things we've learned the hard way is that the cardiologist will say, patients at relatively low risk for surgery, and that's wonderful. And the surgeons will always say, I can get anybody off the operating table alive. Well, I mean, that's probably true, but that doesn't really help us if the patient's estimated survival from a cardiac point of view 6 months later is dismal. You're really not doing anyone a favor. And so we have learned the hard way that we need from the cardiologist or the pulmonologist, whoever it is, what's the natural history, what's the prognosis of this patient 6 months and a year later? Not just will they get extubated or will they not have a massive MI and arrest on the table. And that's actually made a huge difference. Well, we didn't have a lot of mortality to begin with, but it's really improved our outcomes considerably by asking that kind of question and insisting that we get not just the sense that patients cleared for surgery and they're mild to low risk or moderate risk. That's just not a very helpful statement. They might be at relatively higher risk for surgery, but once they get through that, they should be fine for a long time. So that's the kind of thing we need to know and decide what risk we're going to take. Functional status. So frailty is an area that certainly in the geriatrics area, and as the population gets older, that is a term that's around a lot these days. Refers to decreased reserve, resistance to stressors, resulting from cumulative declines across multiple systems, and leads to adverse events, adverse outcomes in response to various stressors. So we know that by any definition, 50% of dialysis patients are considered frail. Even a third, actually, less than 65. And as I mentioned earlier, it's a predictor of mortality. It is associated with some early poor outcomes, and as I mentioned, with early death after transplant. How do we assess this? That's one of the problems we have. We don't have good tools. There are questionnaires, there's timed up and go, there's a grip strength. None of these are really validated in transplant candidates. So we just extrapolate from other areas and assume that this actually will tell us. So this is an area of interest, increasing interest in the transplant community of assessing frailty and using scales, validating the scales. And certainly Johns Hopkins has pioneered in this. They have an online Hopkins frailty calculator, which unfortunately you have to pay for. But that will give you an idea of kind of what they're doing. And I would have to say, to our embarrassment, that the person who's the dean of the School of Public Health at Columbia is the person who's invented this, and we have not yet adopted it. So shame on us, but that's going to change soon. So we make some assessment, and we've been using the timed up and go, which I have to say, is simple to do, and that's why we did it. The patient is in a chair. They have to get out of the chair. They have to walk some number of feet, turn around, and go back and get back in the chair. So that gives us some idea. If the timed up and go is over 15 seconds, then we decide, time out. We got to take a look at what's what. The problem with it is you could have bad arthritis and otherwise be quite healthy, and that is going to make you look really bad. We have a lot of diabetics. You could have one leg, and it may not be so simple to get out of the chair and walk 6 feet, and you might be actually not in bad shape otherwise. So it's very limited, and again, it's not really validated. So we need to do better in assessing this. And there was at the recent meeting, some abstracts where people are doing what they call T for T, training for transplant. So they take the patients. I'm not going to go through all this, but they do an evaluation. Some people get listed. Some people are turned down. Of the people who are turned down, some get into a training program. And a lot of them are obese. Some are frail. Some are obese and frail. A few people drop out. They had 17 people in the program. We're still doing it. 22 people got listed. And actually, again, the numbers are small. It's quite new, but 41% got successfully transplanted. So they do what has been termed by the Hopkins group prehabilitation. So you can take the patients that don't look that good and say, okay, you got to meet these goals. And then you'll be, if you can do that, then you'll be a good candidate for surgery. It seems, at least initial data suggests that can be done. So it is an option for patients. If they're in bad shape and they can't get into better shape, obviously there's a conclusion that we can draw from that. And that's just the prehab, data on prehabilitation, or the reference to that. So the next issue is, so we have a patient, they're in pretty good shape, we've tested them, they're okay. What kind of kidney should they get? And in one way, it's a really simple answer, which a lot of people still have trouble with, which is, this shows the live donor kidneys in the yellow, I guess, and red, compared to the two light and dark blue, compared to the deceased donor kidneys. And there's no question that live donor transplant, no matter what you look at, patient survival or death-censored graft survival, is much better with a live donor kidney. And this is a concept that people have a little trouble embracing, which is someone's grandchild who could be 30 years old donating a kidney to someone who's 75. People think that sounds like kind of insane. You're going to put someone through that for someone who's not going to live that many years. It's not. I wouldn't dismiss the question, but I think many people feel that their older parents or grandparents have been very significant figures in their lives and want to give something back. Can make a big difference in someone's life, even if it's for not for 30 years, but for a short period of time, and it's something we should seriously consider, and is actually, as I showed on an earlier slide, being done much more commonly. That's one of the things that we stress as well. From the point of view of the recipient, is clearly the best thing, and this breaks it down into young living donor or older living donor. It breaks by 55. But you're not going to have live donors who are 65 or 70, or very, very rare. Doesn't matter the age of the donor, still gives you a much better survival. And if you look at the quality of the deceased donor kidney, well, the better deceased donor kidney, you'll do better. The so-called standard criteria donor, this is an old term, no longer in use, or versus the expanded criteria donor, the lesser quality kidney does worse. If you look at the graft survival, actually the good quality deceased donor kidney starts to approach the older live donor kidney, but still a good quality younger live donor kidney is still the best option overall, no matter how you slice it, for elderly patients on the waiting list, or elderly patients with end-stage renal disease, whether they're already on the waiting list or not. What kind of kidneys are they getting? And we analyzed the UNOS database. There's a lot of things on here. I'm just going to point out a couple of things. We looked at the age over 65 who got transplanted a few years ago. The average age was 69. That's the recipient characteristics. There's a lot of hypertension. There's a lot of diabetes. And actually, preemptive means getting a transplant before they go on dialysis was about the same. The numbers are huge, so the statistics are a little hard to interpret, but they had a good amount of preemptive transplantation, which is a very important factor, as I'll show. The donor age, they get older donor kidneys, quite a bit of a jump. The average age is, the mean is 45 years. The terminal creatinines are slightly higher. Hard to know if that really means much biologically. The risk score, and now all deceased donors have a risk score associated with them, where the higher number indicates a higher risk for graft failure, so they're getting poorer quality kidneys. The outcomes are basically what I've shown on other slides. So the older people are getting older kidneys. A very interesting fact is that, as I showed, rejection by recipient age, so the older the patient, the lower the incidence of rejection by recipient. However, the older the kidney, the higher the incidence of rejection. For some reason or other, older kidneys seem to be more immunogenic, something you wouldn't necessarily expect. This is just shown graphically over here. Whereas the rejection rate goes up as the donor gets older, but it goes down as the recipient gets older. But if you look at you break down each age group to see how this really breaks down. So you take the patients over 70 and you look at the donor age, even in the 70 age group, as the donors get older, the rejection rate goes up. And it's true virtually in every single age group. The older the donor, the more rejection there is. Reasons are unknown, but it's quite clear. And this translates into graft loss. And this is censored for patient death, but again, patients with older kidneys have more graft loss, probably due to more rejection as the donors get older. So we're potentially not doing our patients a favor by giving them older kidneys and putting them at more risk for more rejection, more need for immunosuppression, and higher rates of infection. Our new system that just came into effect in 2014, unfortunately, or fortunately, but for old people, unfortunately, it generally allocates the best kidneys, as I mentioned, for those candidates with the best expected survival. The idea is to avoid life years of kidney transplant function. The gross example is putting a 20-year-old kidney into an 80-year-old recipient, as opposed to a 20-year-old recipient. So the 20-year-old recipient can live for 20, 30 years or more, whereas the 80-year-old just isn't going to live that long no matter what we do. And so you've lost all those years on potential life years of kidney transplant function by using the younger kidney in the older recipient. So the new system prioritizes the better kidneys for the patients with the longest estimated post-transplant survival. Unfortunately, we know that's not necessarily the best measure for older patients. So the older people get the worst kidneys. And also, fewer older people are now being actually transplanted based on the new system. I don't want to be too judgmental. These are decisions that have to be made when you have to rationalize care. We can't magically produce more kidneys, so some people will get, some people won't get. If we change the allocation, then some people who were getting before are not going to get, and other people who weren't having access to transplantation will have access. This is the nature of organ transplantation, unfortunately. So what do we know? Well, so one thing we know, if we're taking these poorer kidneys that have a high risk index on them, again, the higher the risk index or the profile index, the worse the kidney, and those what the older people are getting, how can we maximize the benefit? And so this looks at patients who stay on the wait list and or decide I'm waiting for a good kidney. compared to patients who get transplanted right away before they're on dialysis and say, I'm approaching dialysis, I want to get a transplant, give me any kidney you got. And that's going to lead to getting a poor quality kidney versus those people who wait around on the wait list and then end up with a poor quality kidney anyway. And it's quite clear that the patients who are over 60 who get transplanted prior to going on dialysis, even with a poor kidney, will do better than sitting on the wait list saying, I don't like that kidney, I don't like this kidney, give me something good. They're not doing themselves a service. So if we're going to use these kidneys, we need to use them, really before the patients end up on dialysis, if possible, which unfortunately our system doesn't allow. And the even worse news is that it's estimated that half of the people who are 60 years of old getting on the waiting list will die before they get a deceased donor transplant. So it's a lot of stuff here. It's probably not that readable, but this is the easiest one to look at. This is the time to mortality. And within about 5 years, half the patients on the wait list over 60 will have died. And you can see that by 5 years, approximately equal number may get transplanted. So half the patients will die, and maybe half the patients will get transplanted by sitting on the wait list. So they could do a lot better by getting transplanted earlier and not taking their chances on the wait list, where their mortality is generally on a very high side. As I mentioned, the other thing that we do is patients with the longest waiting times are prioritized for kidneys in a sense of fairness, that people have been waiting a long time, and this is, again, has always been the case. If you've been on the line for a long time, you should get a chance, you should get transplanted before someone who just got listed. So that for the older person who would do much better taking an older kidney, they have no way of getting access because the system says the person who's waiting the longest is going to get that kidney, not the person who's waiting the least period of time. And unfortunately, 60% of older kidneys, what are deemed poor quality kidneys, where the profile index is over 85%, are discarded. They're considered not transplantable. And so I think there's a huge mismatch between the use of these kidneys and the potential benefit that could come to older patients on the list. And there's no way to prioritize people who, at the moment, who are not yet not even listed, who are not on dialysis, to get these older kidneys ahead of people who would rather take their chances sitting on the wait list for a better kidney. Finally, a few words about immunosuppression. What about the drugs? What's the best drug regimen to use? I'm really not going to say much about that because there's not time. Do they metabolize their drugs differently? How much attention do we need to pay? Since we know that death from infection is a risk. Well, part of the problem is that almost no one does a trial of a new immunosuppressive drug looking at patients who are 70 years old. They're like, forget it, they're out. Nobody wants to know. So it's all kind of guessed. It's all looking at single-center studies, registries, which have their advantages and disadvantages. We know the immune system gets older as we get older. We have fewer naive T cells, our memory cells, not only in our brain, but in our immune system are not working so well. T cell signaling is reduced, and presumably more regulatory cells that are down-regulating our immune system. Perhaps some of that explains why there's less rejection and more infection. So there's been a little bit of data. One of the drugs we use is mycophenolate. It inhibits lymphocyte proliferation by inhibiting an enzyme, inosine monophosphate dehydrogenase. And a beautiful study was done looking at older patients to see not only is the pharmacokinetics any different, but are the pharmacodynamics any different? Do they absorb it? Is the drug level the same based on the dose? And is the ability of the drug to inhibit IMPDH, or the percentage of IMPDH inhibition, is it the same in older patients? And the answer was yes. That if there's lower rejection in older patients and a higher risk to die, it's not due to any difference in the handling of mycophenolic acid in the elderly patients. The other drugs that we use, the major one is tacrolimus, and there is some difference here that the levels tend to be higher for any given dose than they are in younger patients. The same is true for cyclosporin. And so probably we could get away with lower doses of the calcineurin inhibitors, may be adequate in patients. And that's one thing we could pay attention to. In terms of pharmacodynamics of the drugs, we don't have any idea regarding the calcineurin inhibitors and downstream effects, whether the pharmacodynamics are different. We just know the drug levels tend to be a little bit higher at a given dose. And one study was done that looked at older patients giving very minimal early, much less potent early immunosuppression, and it didn't work. They slowed up the tacrolimus dosing, didn't give it immediately. They stopped the steroids very early. They gave less potent, what we call induction therapy, and the patients did poorly. So it's not, they can't get away with nothing, that's for sure. In terms of maintenance immunosuppression, we do better with tacrolimus. Steroid use doesn't seem to make any difference, whether it's acute rejection, graft failure, or mortality. So steroids probably can be stopped very early after transplant in older patients. Mycophenolate seems to be a benefit as well. So we have, some small guidelines about the drugs. So wrapping things up, we've learned a lot. Some lessons we've learned hard. We need to choose our patients carefully. We need to make sure they're psychologically prepared. Remember, their immune systems are not as strong. They're going to do better with good kidneys. I haven't really addressed this, but in some patients, we're quick to treat rejection with high-dose steroids. In older people, I think that's a mistake. I think we need to absolutely prove that there's rejection before we treat, and we need to pay attention to any signs of covert infection when anything isn't right in an older patient. So more people are reaching end-stage renal disease, more people are being listed, and more older people are getting transplanted. The outcomes are very good in terms of graft survival. Live donor is the best option, no question about it. Deceased donor, even from older, poorer quality kidneys, still offers a great benefit compared to dialysis. Minimizing dialysis time is rather crucial. And there's a lower risk of rejection. It's not no risk, and so we can't just think, well, they don't really need any immunosuppression at all. This is far from the truth. They just need to be monitored carefully and not given medicines or doses that they don't need. Okay. That seems to be, there's another slide in here somewhere. Just went back to our original patient here. Let's see. I can do that from here. So what about our guy? So he ultimately got transplanted. He did wait quite a while. He got a standard criteria donor kidney. He had a little bit less aggressive immunosuppression, but from an induction point of view, steroids were stopped early. He had some problems, not surprisingly. There were some bumps in the road. He actually had an MI after transplant. Got over that. The kidney didn't work right away. Needed a couple of dialysis treatments. Went home on day 10. His discharge creatinine was 1.4, and to this day it is still 1.4. And this is 4 years after the transplant. He's traveling around with his grandchildren, going to Disney World, living a happy life. So this is an article from 1975 that talked about transplant in the older age group, which was considered over 50 back then. Now, a very recent article says, from the Scandinavians, it says 80-year-old people are perfectly fine to transplant. So we've obviously moved quite a distance in that period of time. Thank you very much.
Thank you, Dr. Appreciate it. Before we open it up to the audience, I had a question for you. I think it's, we often take for granted the country we live in. It's amazing to me that we can think about the possibility of how to provide a transplant to an 80-year-old. When other countries, the option is with done in other industrialized countries, England, Canada, where the healthcare system is different?
So some of this data does come from other countries. So in Europe, they have, many of the countries are banded together in what's called Eurotransplant. And so they have what's called a Euro Seniors program, in which they specifically take, for patients on the waiting list, they take the older kidneys and specifically target them to the older patients in the goal of minimizing the waiting time on the list. And the outcomes are quite good. So comparable countries are transplanting older patients. I think if you go down the scale of wealth in the country, then kidney transplant is a whole other deal when you're, when most people don't have access to dialysis. It's hard to say that you should be spending a lot of money on kidney transplant, and particularly in an older population. So then, as it is in a lot of places, if you got the money, you can make it happen. But otherwise, you're kind of restricted in your access.
Yes. Questions, comments? It was all, Eleanor.
I have a question, a bit of a sticky issue. People who are on dialysis, there's well documented cognitive dysfunction. So how do you determine if your outcomes are poor if somebody has dementia and that's undocumented? How do you figure out this older person really has a progressive dementia versus they just have some cognitive dysfunction due to their dialysis, and once they get a transplant and they're feeling 20, not 80, they're going to do a lot better. So I have to say that, we have certainly this institution run into situations where transplant somebody only to find out later on they were really having trouble coping, because of ongoing cognitive issues.
Well, we don't have an easy mechanism to do that. One of the comparable areas is in heart failure. So we know that a lot of patients on dialysis, LV function isn't that good, and when they get transplanted, LV function gets substantially better. So with a similar issue with trying to treat those patients, and right heart cath and things like that, sometimes there's a issue with volume mostly. The cognitive function, we just don't have those studies. I think that we are now recognizing that to a certain degree we stumbled into transplanting more and more older people. They're on the list, and the name comes up. If you haven't got a good reason, you're going to get the kidney. So now we're starting to look at all the data. I don't know. One can imagine things that aren't that practical and might be not very helpful. More aggressive dialysis for a short period of time to get better. Or was there pre-morbid cognitive function, whatever, the imaging and what kind of testing could be do that would suggest that this is reversing or irreversible. But it's a real problem. I don't think we have the answer to that.
One question here, Mike.
So you mentioned John Oliver, so some of us watched the clip, and according to John Oliver, dialysis corporations are evil, and they don't want their patients transplanted because they can't bill for them on dialysis. So how is that really addressed?
Well, two things. So I don't know that that's, I think that the transplant issue in terms of the patients on dialysis, there's a huge number of patients out there that need dialysis. I don't think dialysis units are all that concerned about people getting transplanted. I don't know this for sure, but there's no shortage of people, unfortunately, who end up in end-stage renal disease. I think the issue is the quality of the education. And, we all know that we're all pressed for time in everything we do. It's probably not that different in the dialysis units. And I think perhaps the quality of education, people don't have time to really sit and discuss the issues with the patients, is more the issue. I don't know that, I can't speak for individual units as to how they perceive their economic interests, but I suspect that we could do better about educating people about the benefit of transplant. And the irony is, it's not like if everyone over 65 and every dialysis unit got listed, they're not going to get transplanted tomorrow anyway. They're not going to have the kidneys. So some percentage might get a live donor transplant in a short period of time if we are able to tweak the system a bit so that we can get the older kidneys into the older patients in a short period of time, but they're not going to, I don't know how they, honestly, how they achieve that, but I think it's the issue of quality education that's given, and probably, I don't know, it's evil intent.
In that episode, I found that misleading to the public in a way, because they're implying that all these people could get transplanted, but the dialysis corporation isn't. And so I think the person that's just generally watching that's not a medical expert thinks that we're all that's certainly not the case.
Yeah.
Well, some of the time.
One last question.
Any experience with the cardiopulmonary exercise testing compared rather than just express test?
Not really. There's really no good data. This is all a field that's evolving. So what kind of testing could we do? What would be predicted? These kind of data are needed. In some of these early studies of pre-rehabilitation, I don't think they're doing that sophisticated testing. I think they're just doing simple, physical therapy with training and that kind of thing.
Well, we want to thank you for being here today and for honoring us with your presence. And we want to send you back home.
Okay.
With a Louisville Slugger.
Well, thank you. That's
okay.
Fantastic.
So David Cohen, Medicine Ground, University of Louisville, May 18, 2017. Thank you very much. You guys have a good day. Thank you so much. I appreciate it.
Top 20%, 21st percent.